Okay, thank you. Thanks for that. Thanks everybody for joining this evening. Welcome to the Journal Hand Surgery European Volume Journal Club. We've got an hour this evening to talk about some really exciting papers focusing on arthroplasty for thumb-based arthritis. We've got a brilliant lineup. We've got first up a paper talking about the Electro Prosthesis compared to suspension arthroplasty. And we're really delighted to welcome Matthias from the author team to talk about that, which will be presented by Carol Chan in a minute. And then following on from that, we have a paper looking at the ivory prosthesis. And we have Alain joining us from France to talk about his experience with that as an author on that paper. That'll be presented by Obi, another hand fellow. And then we have some expert opinions from Sumed from Wrightington and Nadine from Belgium, and we're really grateful that they've joined us. And as well as that, we have Tim Hems, the handling editor who managed both of these manuscripts through the editorial process of the journal, sharing the insight from behind the scenes of the journal. So hopefully it'll be a really interesting evening. Hopefully you've got lots of questions about thumb-based arthritis and arthroplasty. Really looking forward to everybody taking part. And we're going to begin straight away with the first paper, which is actually a flip from what's on the advert. We're going to talk about the Electro Prosthesis, the old prosthesis first. So I'm going to hand over to Carol. Thanks very much.
Just sorting out the screen. Okay. Good evening, everyone. I'm Carol. I'm the TIG Hand Fellow at Leeds. I'm presenting tonight's first paper, which was published in the journal in June 2020. Dr. Stefan Frauscher and his colleagues from Austria published their work on Electro Prosthesis versus resection suspension arthroplasty for thumb carpometacarpal osteoarthritis, a long-term cohort study. The author starts by highlighting trapeziectomy alone, or RSA, is widely established treatment in osteoarthritis of thumb CMC. However, there's no evidence of a superior technique. The paper's introduction highlights the drawback of these methods being proximal migration, leading to compromised pinch strength and disability. The goals of arthroplasty is to maintain thumb length and achieve anatomical reconstruction of the thumb to give better functional results in terms of the range of movement, the dash scores, a stronger grip, and a faster and better pain relief. The authors highlights there are various thumb CMC prostheses, but the results are inconsistently reported, especially regarding complications or revision rates. The author states the main drawback of arthroplasty is aseptic cup loosening, leading to revision rates of 42 to 51%. This study looked at the long-term comparison between the electroprosthesis versus resection suspension arthroplasty. This paper is a retrospective cohort study looking at various radiological clinical outcomes, the DASH score, and patient satisfaction. The demographics are well described. In the Electro group, there was 34 patients in 37 thumbs. In the RSA group, there are 18 patients in 18 thumbs. The mean age was 56 years in prosthesis group and 58 years in the RSA group. There were a higher number of females in both groups. The allocation of treatment was voluntary. Patients received both verbal and written information about the two different treatment options, and they could choose between which one they can have. Both procedures was done by two surgeons. Both are level 3 experienced surgeon according to the Tang and Giddens level of experience. The selection period was between March 2004 and April 2006. The inclusion criteria was stage 3 or stage 4 thumb CMC osteoarthritis with a minimum follow-up of 12 years. Patients with rheumatoid arthritis, history of trauma, STT osteoarthritis, and previous thumb CMC surgery were excluded from the study. The mean follow-up was 13.3 years overall and 13.1 years in the prosthesis group and 13.6 in the RSA group. The Electro Prosthesis was introduced in 1996. It is an unconstrained, uncemented, unipolar prosthesis consisting of the stem, the cup, and the head. The stem is made of titanium-coated hydroxyapatite. Hydroxyapatite is used to coat implants to help achieve osseointegration. The cup is cobalt chrome steel with hydroxyapatite coating. The head is made of cobalt chrome steel. The postoperative regime is 3 weeks immobilization in a splint, followed by 6 weeks of hand therapy. For the resection suspension arthroplasty, half a strip of ECRL is taken. A bone tunnel is then made from ulnar to dorsal on the metacarpal. The suspension is secure with a micromitex, and a K-wire is inserted from the first to the second metacarpal. Postoperatively, the hand is immobilized with a splint for 6 weeks. The K-wire is removed at 6 weeks, and the patient has hand therapy for another 6 weeks. The follow-up was conducted at 2, 4, 6, 12, 26 weeks, and also at 1 and 2 years. The long-term follow-up was at least 12 years minimum. The outcomes for the prosthesis group was radiographic findings such as dislocation, subluxation, implant loosening, cup tilting, and adjacent joint osteoarthritis. For the RSA group, the thumb length and adduction deformity was measured, and the radiographic findings of osteoarthritis in adjacent joints were looked for. At the long-term follow-up, the DASH scores, the range of movement, the subjective grip strength, patient satisfaction, and the visual analog scale for pain were measured. Complications were recorded for both groups. The DASH score is better for the Electro group, 27 versus 37 for the RSA group. DASH is a patient-reported outcome measure, and the lower the score, the less issues the patient has. However, despite a better score, there's no significant statistical difference between the two groups. There was no difference in the pain scores. Radial abduction was similar, with the Electro patients having 56 degrees radial abduction and the RSA group having 51 degrees. In terms of palmar abduction, 50 degrees in the Electro group and 57 degrees in the RSA group. Opposition was measured by distance between the thumb and the little finger MCP joint. Both groups were able to touch the MCP joint. None of these outcomes showed a significant statistical difference. The two outcomes that did have differences are the subjective grip strength, which was measured on a scale of +2 to -2, with +2 being a high gain of strength and -2 being a high loss of strength. 0 was no noticeable difference. Patients reported 0 for the Electro group and -1 for the RSA group. The other statistical difference is in patient satisfaction, and this was determined by whether the patient would have the same operation again, of which 44% of the Electro group would have the prosthesis again, and 92% of the RSA group would have the same operation again. The authors reported 72% complication rate in the Electro group, with 23 major complications in 22 patients. The main cause of complications were aseptic cup loosening, and they saw 17 cases of this. There was 4 cases of cup tilting, 1 dislocation, 1 allergic reaction. 17 patients required revision to an RSA. At surgery, 15 of the 17 patients had local metallosis. In the RSA group, there were 2 major complications, 1 proximal migration of the thumb and 1 neo-joint instability. Overall, this study shows less than 50% survival, as demonstrated by this Kaplan-Meier survival curve. It shows that failures often occur early, within the first 3 years. 53% of the implants were removed and converted to an RSA. There was no revision in the RSA group. In summary, this study was a retrospective cohort study looking at Electro versus resection suspension arthroplasty. There was reported high complication rates in the prosthesis group of 72%. It was a small number study. There was no clear primary outcomes in this studies. The authors did include some subjective parameters. There was no randomization, and the patient was able to choose the operation after verbal and written discussion. I wonder if there was any potential bias during the verbal discussion. There was no preoperative outcome data, and the outcome measurements was made by an independent examiner, However, we do not know the level of experience of the independent examiner, whereas the surgeon levels were stated. The authors concluded that the Electro Prosthesis cannot be recommended. The authors did suggest that a CMC prosthesis could give a better grip strength and a lower dash score, but only if the new prosthesis could overcome the complications encountered in this study. So my question to the authors are, did you notice greater issues in the Electro group in younger patients? And I now hand over back to the panel for discussion.
That's great. Thank you. Thank you very much, Carol. And I want to go straight across to Matthias and see if you would like to respond to Carol's finishing question.
Thank you very much. Hello to everybody. We have looked at this question again, and we did not find any correlation between younger patients' age and the patients being more prone to have any dislocation. So we didn't find any association between young age and the probability that the prosthesis will get dislocated.
That's great. Thank you. Thank you, Matthias. And I'd really like to bring in Nadine now. Thank you again, Nadine, for joining us from Belgium. And I think you had some questions about this paper for us.
Yes. Good evening, everybody. So, Matthias, what information did you give the patients between 2004 and 2006? What did you tell them so they could choose for a prosthesis?
So we presented both procedures to the patients, and we also mentioned the advantages both and the disadvantages to the patients. So regarding the Electro Prosthesis, we mentioned a better functional outcome in terms of range of motion, better grip strength as advantages, but we also mentioned that we can't see how the prosthesis will work out in terms of dislocation. We did mention this complication to our patients, and they could weigh out for their own if they would choose a more a technique which was well known or a more newer technique in terms of the prosthesis.
If they ask you how long will this prosthesis last, what could you answer then?
We answered them that there are even early dislocations, but there are also several patients who didn't needed any revision surgery. So the prosthesis could also be a very sustainable method which lasts 10 years plus. Mm-hmm. So we clearly talked to the patients that there is a certain risk for revision surgery, but they could expect better functional outcome compared to an RSA method.
Yes. And how much is the 10-year survival in your paper? Because it's only a figure.
Yeah, you're right. We only included the Kaplan-Meier curve, and the 10-year survival rate is exactly 50%.
Mm-hmm. Okay.
50% had to be revised. Yeah.
And what treatment are you using now in your hospital?
Now we are currently performing the touch prosthesis, but only for levels for stage 3 osteoarthritis patients. For stage 4 osteoarthritis patients, we perform the RSA method.
Yeah, you mean the STT osteoarthritis, yeah. Stage 4, yes. Although there is discussion about this, if it is not symptomatic, probably you can ignore it.
Yeah,
and this is
exactly. We referred in our paper to the initial description by Ethan, but we also have to say that most patients were stage 3 in our study. There were only 2 patients with stage 4 in both cohorts, so they are.
The technique with resection suspension arthroplasty, there was no reference in your article.
You're totally right. The technique was first described by Professor Martini from Heidelberg, And while writing our manuscript, we didn't find this technique being described in any publication. It's only described in his textbook. So we decided to describe this technique very detailed in our manuscript, but unfortunately we couldn't add any reference.
And still, Carol could find a figure of that.
Yeah, I think this figure is from Martini's textbook, I think.
Okay. Yeah.
She's doing her reading, so that's really great.
Or she was better at researching any resources.
But what's been really great there is there's a couple of questions that have come up about this, about STT, and I think you covered that, and about which tendon you were using in your suspension. So that your suspension involved which tendon?
ECRL.
ECRL.
Yeah, and that's the thing why this method isn't described that often, because most often the flexor carpi radialis tendon is used, like the Epping method, which is widely used in the German-speaking region. That's
brilliant. Well, thank you very much for that. And we're going to carry on with some more discussion. But I think will be really interesting to talk. We've talked about how you've changed your prosthesis and moved along, and it'll be interesting to talk now about another study of a different prosthesis, Alain's experience with the ivory prosthesis. And I'm going to invite Obi to come and present a summary of that paper for us, please. Thanks.
Okay, yes, many thanks. Good evening, ladies and gentlemen. Thank you very much for asking me to present this paper on behalf of Dr. Alain and his team, who describe results following the implantation of 110 ivory prostheses for trapeziometacarpal osteoarthritis, with a minimum follow-up of 10 years at the Dijon Burgundy University Hospital in France. My name is Obi Onyekwelu. I am a nationally appointed hand fellow, about to start my placement at the Wrightington Upper Limb Unit next week. So let's dive right in. So the problem that Dr. Alain and his team wanted to address is the treatment of symptomatic trapeziometacarpal osteoarthritis, which has been refractory to conservative treatment after at least 3 months. They suggest using the total TMCJ prosthesis, and they actually implanted the ivory implant. The outcomes include primarily joint survival, and secondarily pain, key, tip pinch and grip strengths, quick dash scores, satisfaction and complications. This is a level 2 prospective case control study. Now we know that several surgical techniques are currently available to address painful TMCJ OA, and the current gold standard is trapeziectomy with or without ligament reconstruction and tendon interposition. However, this has drawbacks in terms of partial weakness of pinch strength, as well as a documented and described loss of thumb length. However, we are still unsure as to the clinical significance of this. Comparatively speaking, total TMCJ replacement allows a faster return to activity, pain relief, recovery of mobility and strength, but the drawbacks include dislocation and loosening as previously described. So the study design was undertaken over 3.5 years by the single senior surgeon, Dr. Alain, at the Dijon Burgundy University Hospital in France. He implanted 110 ivory prostheses in 95 patients, 80 of whom were unilateral implants. For these unilateral cases, they compared the results with the unoperated contralateral side. 2 of the authors did so. It's worth noting that the ivory implant was produced by Stryker between 1994 to 2017. Now, it was completely flexible since all of the individual components were separately interchangeable. After the introduction of dual mobility implants, the ivory implant has declined and it is actually no longer commercially available. However, the ivory implant stem can be used in place of the current Stryker-produced Movis implant stem if this Movis stem is a bad fit for the metacarpal. The inclusion criteria was patients who experienced pain at rest or affecting the activities of daily living after at least 3 months of conservative treatment, which had failed for them. They excluded patients with STT osteoarthritis and those with stage 4 radiographic changes as per the Dell classification. This includes patients with pantrapezial osteoarthritis as demonstrated in the illustration and a total loss of joint space with less than 8 millimeters trapezial height. They used a number of statistical analyses, some of which are well known, like descriptive statistics, binomial tests, Wilcox and Mann-Whitney, and Kaplan-Meier. Others are less well known. Looking at their Kaplan-Meier survival curves, they demonstrated 95% implant survival over 10 years. There were 4 cases of dislocation and 2 cases of traumatic trapezium fracture. Looking at their secondary outcomes, the pain scores were analyzed out of 10 using visual and analog scores. The mean was 7.5 pre-op, and after 10 years, this was down to 0.2, so a marked reduction. Looking at their key pinch, tip pinch, and grip strengths. Pre-op, there was a marked difference in the unilateral cases compared to the unoperated contralateral side. After 10 years, these strength measurements approached the contralateral measurements from 10 years ago. However, it's worth noting that they did not repeat the contralateral strength measurements 10 years after the implants were placed. Patient-reported outcomes were favorable, with 88% of patients being satisfied or very satisfied. And the quick dash score, the mode was 0, indicating no disability in most patients. So in summary, the paper describes very good results after 10 years of follow-up with 95% survival. Now the indications are wide, as they demonstrated that neither profession, nor age, gender, medical history, or even radiological score played a determinant or decisive role in the outcomes. However, it's worth noting that the authors had excluded patients with a Dell classification score of 4. And these patients with STT or pantrapezial osteoarthritis, it's still debatable as to which treatment method they're best served with. They also indicate that the pain relief and return to activity are fast following implant, and there are no cases of loosening. So many thanks for listening. My question really to the panel was what we can learn from the ivory prosthesis that can help us presently. And once again, thanks for the opportunity to present.
Thank you very much, Obi. And I'm going to bring Alan in as an author now. So Alan, so what can we learn from ivory? I think you're on mute.
It's okay?
Mm-hmm.
Good evening, everybody. Yes, what we can learn, that's a CMC prosthesis. It's a good option for the treatment of the osteoarthritis of the CMC joint. This is the first lesson. And the ivory was one of the best prosthetists at her time in the panel of prosthesis. With the special thing, it was the possibility to have the polyethylene and the cup in 2 parts. It was one of the very good thing. It was the point who convinced me to use this prosthesis, because I started my experience with what's the name? I forgot the name. Not the Maya, but the sorry, I forget the name. But
Arpe, you mean? Arpe?
Arpe, yeah, sorry.
Okay.
With the Arpe, and when I saw the conical cup and the possibility to have the polyethylene free, it convinced me to use this prosthesis. And so I perform 600 cases of ivory.
A lot.
A lot.
In fact, on that note, we're going to go to Sumed, who's got some questions about it, and a couple of questions have fired up here. Did any of your patients have trapeziectomy on the other side? They had ivory on one side, trapeziectomy other side. Any patients have? Did any patients have ivory
Yes.
and trapeziectomy?
Yes.
Any patients? Or?
Any? I don't understand the question.
Did any patient have ivory on one side?
Yes.
And trapeziectomy on the other side?
Yes. Maybe it's a patient with the first trapeziectomy,
Yeah.
and after he came to me, and I proposed a prosthesis. There is some cases I made trapeziectomy. If I can perform a prosthesis, I propose trapeziectomy.
Okay. And the other question is, given the good results, why has ivory been withdrawn? Why is ivory gone when it was good?
Because Stryker decide to stop it because they have another project with the movies.
Okay, so that's very interesting. So Jonathan Hobby has asked that question. I think you'll have to ask the Stryker rep.
And now the future is a prosthesis with double mobility.
That's great. And Sumed, you've got quite a few questions, I think, about this, haven't you? So sorry, I just wanted to get the
No, that's fine. No, thanks for inviting me, Jeremy. So Alan, congrats on a very good paper. I think it's fair to say it's a landmark paper in many ways, with a 95% survivorship at 10 years. Something like that would rival the results of a hip replacement paper, for example. So one of the things I just wanted to pick, not criticize, but just to inquire a little bit more about was your selection criteria in your cohorts, the inclusion criteria. You excluded grade 4 DEL, which speaks to the severity of the arthritis and the presence of STT joint arthritis. I just wanted to know what you did with patients who had that little bit of subluxation at the level of the CMC joint, and patients in whom the MCP joint was involved as a sort of compensatory mechanism. When the first metacarpal adducts, did you exclude those as well? Because you had very strict criteria, didn't you? You didn't want to have any patients with STT changes, which is great, and that is reflected in your results. But what did you do with these patients? Because subluxation sometimes is difficult to measure in that.
For the MCP joint, if you have hyperextension in a moderate degree till 20 or 30 degree, you can reduce this with when you establish the length of the thumb with the prosthesis. So I do nothing more on this MCP joint. If the prosthesis don't solve the problem, I perform capsuloplasty for reduce the hyperextension
at the MCP joint.
MCP joint.
Yeah. And how much subluxation did you accept in the initial stages of your trial? Or did you 50%, 25% subluxation? Did you have a cutoff
of the CMC joint?
Yes.
I have no restriction.
So you would even do it in a completely sublux joint for the purposes of this
reduce the subluxation.
Right. Okay.
The one thing is very important. Why you have so good results? I think we have the procedures change. The principles of the procedure from the beginning, I tried to remove all the attachments of the base of the metacarpal and remove all the osteophyte, the horns of the trapezium. And I think it's a very most important things. And the results are correlated of these things in the procedure.
Sure. So, which very neatly brings me to the next question about the technique, Alan. It's about the gauging the length sometimes can be quite difficult. And there's always the fear that by doing such a radical release, maybe taking too much bone away, that you might end up with a situation, on the one hand, that you might end up with a prosthesis that is too loose. And I suppose to a certain extent, you can change that by using a straight neck. But what do you do to gauge that length adequately? Very often when you see x-rays, you feel that maybe the first metacarpal is over-lengthened compared to the second when you look at your some of the films. Do you have any tips of how we can, solve this difficult problem in all cases?
My goal is to reestablish the length, and I look where is the top of my thumb comparative to the hip joint.
Right.
But the thumb do not be more this level. And I perform now I perform the prosthesis with a touch prosthesis, and I try to use every time a neck of 8 millimeter, the medium size, straight, and 8 millimeter. So I perform my osteotomy for this goal.
Right. The other question was about the fact that you essentially used conical prosthesis. Was that because they don't have spherical? You didn't have a spherical variant for this particular type of prosthesis. The ivory didn't make spherical. Does that make it even more difficult to get it accurately placed? Because with the spherical, you can adjust the position while we can't do that with the conical. So any tips regarding accurate placement of the trapezium in that sense?
The question is why I prefer use a conical cup.
Yeah.
With the conical cup, you have a primary stability.
Right.
When you put the cup, it's stable. And I tried to put in the first time in the good position. I think it's not a good thing to try to correct the position with the possibility with a hemispherical cup, because you put the cup and you it's very important to have a primary stabilization. If you start to move the cup, you decrease the possibility of primary fixation. In the same thing, I never use I use always the
trial
prosthesis. I don't trial, not trial cup, not trial stem, to preserve my my work on the cancellous bone.
Yeah, that's a very good point. You shouldn't rock the cup, isn't it? You're absolutely right. In your post-operative mobilization schedule, you've said that these patients were more or less left to their own devices. One of the things we are always afraid of is that they would end up adducting the thumb or, moving the thumb inwards, which could result in subluxation. Did you put them in any specific type of dressing for a couple of weeks to prevent that from happening?
When I performed surgery with a single mobility prosthesis at the beginning with the RP, I made, as my teacher professor said, put a cast inside the first wave to preserve the opening of the first wave. And I analyzed this situation because with the earlier dislocation, the patient when the anesthesia go back, they try to move their thumb, and there is a chem effect with a cast in the first web. And I stopped to do this, and I never had more earlier dislocation. So now my dress is only compresses. It's a soft dress, soft opening of the web. So I don't have chem effect, and I never have any more early dislocation. So it's a simple bandage during 2 weeks, and after 2 weeks I have no immobilization. Every patient starts their self-reeducation.
That's great. Alan, just two more questions, Jeremy, if that's okay. So the first one is about decurving stenosynovitis. I know you've said that some patients, or I think one patient had decurvings in the pre-op stage. Is this something that you've seen in patients in the post-op stage, unexplained pain, for example, in knee replacements? Even in a perfectly done knee replacement, sometimes you get, or there is a known percentage, I think it's 30% patients sometimes get unexplained pain. Is that a phenomenon you've seen in some of your cases? May not be in this series, obviously, but is that something that you've come across?
Pain after surgery?
Yeah,
yes.
Unexplained or decurving specifically in the post-op stage rather than the pre-op?
At the beginning of my experience, the pain was correlated when you have a tension in your prosthesis. If it's too big prosthesis, a big neck, a long neck, you have a tension in your thumb, and there is pain early after the surgery. Or what patient analyze like pain is diaesthesia from the collateral dorsal nerve, and it's a kind of pain, but in the majority of cases there is no pain. The pain is a tension. It's a reason that you have control your piston after your prosthesis.
Sure. So now the last question, it's really carrying on the theme that Jonathan Hobby brought up, specifically dual mobility and the sort of thing that companies tend to do when they get bored with a prosthesis, they withdraw it, and that creates a lot of problems for clinicians because you don't know what to do with revising these prostheses. Now that everything is moved to dual mobility, Alan, my concern that now it's likely that originally with your patients, you just had one bearing to wear down because your cup wasn't dual mobility. And now we've given the thumb two bearings, isn't it? One bearing between the head and the PE liner, the retentive liner. And then the second bearing is between the PE liner, which is a soft on hard type of bearing, which biomechanically can create problems. Any ideas about the future as to how we are going to get around this problem? Because this is something that worries lower limb surgeons as well.
I don't have understand your question.
Oh, the question is really about where.
The wear of the polyethylene.
Yeah, because my worry is that you'll end up with double the amount of wear now that you have a dual mobility. So how is your new touch prosthesis or whichever prosthesis they use now, how have they got around that?
The test in lab, in vitro, show no more wear with a double mobility. It's better. You are less wear with a double mobility than with a single mobility.
Right. And to a certain extent, do you think it has to do with the fact that they're using a different type of spacer, the high density polyethylene rather than...
Now, the last generation of touch is with a new polyethylene survitaminé. It's like in the hip.
Lovely. Thank you, Alan. That's great. Thank
Brilliant.
you very much.
Thanks. So very interesting, because we've got two papers on the same topic today. You know, often we have two completely different topics in the journal club, but two papers, same topic, different study designs, different style. Tim, as the handling editor, why did you accept these papers? What was about these two that you thought would be interesting to discuss tonight, and why did you accept them in the journal?
Thank you. Thank you for asking me. Firstly, one of the reasons for selecting these papers this evening was that they are a bit different and therefore worthy of discussion. If I talk first briefly about the paper on the Electro Prosthesis, why did I accept it? Well, firstly, it's a clinical study, a surgical study. The main strength was the long follow-up, and that's particularly in implant surgery, a particularly important thing to encourage. So that was initially, I think, in terms of what it's contributed to the literature, it has confirmed sort of evidence of long-term durability of trapeziectomy, but also importantly reported poor survival with the electroprosthesis. With regard to the sort of review process of this paper, there was some disagreement among the reviewers, initial reviewers, that we had to sort out, and I'll maybe talk about that a bit more later. The initial submission was too long and not very clear, and required a couple of revisions to make it publishable. But that's my overall assessment. And then if we mention the other paper on the ivory prosthesis, again, this was a clinical surgical study. It had some substantial numbers, low loss to follow-up, and very long follow-up, making it underlying a very potentially very useful study. And I'm rather traditional. I still do trapeziectomy for thumb base arthritis, but I was really quite interested in this series that showed a low complication rate and a high survival in a large group of patients. I think it has added substantially to the literature in that regard. This was clearly a strong study as soon as we could see when it was submitted, but there were problems with the initial submission, being too long, English not great, and too many tables. And it did go through a number of revisions to get it to a publishable level. But we do try to work with authors to revise papers if the underlying study is strong and worthwhile of publishing.
What would be your top tips then? We've got a lot in the audience tonight who be submitting manuscripts. Can you give a couple of top tips for trying to minimize the number of revisions that they need to make for their papers?
I think the first thing is we do try in the journal to have a fairly concise style. We want concisely presented papers, as well as looking at the submission guidelines. It's, I think, useful to look at the article by Jeff Hooper, Jimbo Tang, and Rory Wetherell on clarity and brevity in writing for this journal. This is a very useful article on how to write a paper, which actually is a significant contribution even beyond this journal. So look at the guidance on the length of the sections, a very short introduction, clear methods, concisely presented results, and then discussion that concentrate on the findings of the study. So that's the main thing. If your first language isn't English, then try and get a native English speaker to help you revise, to write the paper.
This is some useful points there for those in the audience thinking of submitting stuff. And you did mention disagreements between reviewers on one of the papers. So yeah, how do you handle that? You know, reviewer 2, you know, raises his head. Reviewer 1 says this fine, it's nice, like this paper. Reviewer 2 is just being difficult. What do you do? How do you resolve this?
Well, we may. It depends a little bit on my personal knowledge of the subject, which may help. But if I sometimes don't have a good personal knowledge of the subject, I tend to look not only at the actual recommendation, but what the reviewer has written, and look at the points. Also look to see if there could be any bias in the final opinion. Sometimes I ask for another review, an extra third opinion, to help make a decision.
It's really interesting to see the kind of challenges from that side, which we don't normally get to see, right? Unless you're involved with the editorial process. So that's brilliant. No, thanks for that, Tim. And we do have a few questions. Everybody is very welcome to fire up lots of questions. Jonathan Hobby's put one up in French. So Alain, en français, here we go. Pour les patients qui avaient une trapeziectomie sur un coude et une prothèse sur l'autre, comment on compare les résultats? Did you get that? Was that worse than English? I only have GCSE French. I'm doing my best here. I'm trying. Thanks, Jonathan.
Oh, I made a comparison between the side with prosthesis and the side trapeziectomy.
Oui.
As usual, with
They préféraient un ou autre?
The grip, the jamar, grasp, and the aspect of the thumb, the aesthetic aspect, and
Il y a patient avec les deux. Il dit je préfère trapeziectomy, je préfère prosthèse.
No, never. In my experience, I prefer the prosthesis.
Toujours.
Yeah.
There we go. That's it. That's about 20 years ago I learned some French, so there we go. We do have some other questions, okay? Have you changed to the movies? Is that how you pronounce that one? These are not prostheses I use. So have you, what implant are you using now, Alan?
Now, touch.
Touch,
yes. Since for 5 years.
Okay, and Daniel Heron has recently compared capsulectomy to capsular repair. And he says that removing the capsule, taking the capsule out, gives better results. No more dislocation.
No, I think the stability is inside the prosthesis. So it's very important to remove all the attachments around the base of the metacarpal and do nothing else. Okay. In my approach, I perform at the beginning two flap, a tendomuscular flap with the APL tendon and the tenarian muscles, and on the another side, on the dorsal of the metacarpal and the trapezium. And at the end, I shutter these two flap. And inside, I do nothing. The stability is inside the prosthesis.
Okay, that's interesting. Matthias, do you have thoughts as well about this? Do your group have thoughts about capsulectomy versus capsular repair?
No, we are doing capsulectomy all the time. But as Ellen also says, releasing the first metacarpal is one of the most important points, as the adduction deformity has to be addressed when doing a prosthesis.
Okay, so that's an interesting point. And I'd really like to bring in our experts as well who kindly joined us. I mean, Sumed and Nadine, do you have thoughts about this?
So Alan, just a little bit about the way you prepare your metacarpal. I've seen you do one vertical cut. Do you do a second cut as well, at an angle to the vertical cut to the metacarpal, or is it just one vertical cut only?
The vertical cut at the beginning,
yeah.
But after I remove the osteophyte, the metacarpal base. Voilà. I remove all the osteophyte to be able to move the metacarpal inside the cavity to have the possibility to work on the trapezium perpendicular to the surface. And for do that, you must have a mobility of the metacarpal. It's very important to release everything.
And Nadine, what are your thoughts? What implants are you using, Nadine? Out of curiosity.
I'm using Maya prosthesis, and it also has a dual mobility prosthesis, which I use only recently, since about half a year or 1 year.
Yeah.
Because I think it's more stable, and you can use also a smaller cup of 8 millimeters. Because sometimes the trapeziums are very small, and if you are not very correctly in the center, your cup you can have problems with the cup, that it's not enough covered by bone, and then you can have fractures of the trapezium. Normally a trapezium doesn't fracture, but when there's a prosthesis inside, you see that's one of the complications you can get.
Yeah. Sounds tricky.
If you use a conical cup, you feel more safe for the stability.
I like more the.
No, you can extend your indications with a smaller trapezium if you use a conical cup, because there is a real primary stability.
So in theory, what they say is that for the same diameter, a conical cup offers more surface area. But in practice, I think the spherical cup is easier to insert. Like Nadine said, if you have a small trapezium, I think you find it a little bit easier to introduce the spherical cup. But in theory, what Alan says is true. And I think Alan's proved it with his paper, I suppose, isn't he?
But if the trapezium is thin, you can suspend your cup. It's not necessary, it's not mandatory to put the flush the cup. You can suspend your cup, and it's always stable. It's a difference with a spherical cup. You can't suspend a spherical cup. The spherical cup must be inside the trapezium. And if you have a little trapezium, you can't use a spherical cup with safe. Try it one time and you.
I'm not used to use spherical cups, and I think you have a little bit more place for error. Although, of course, if you only have actually one chance, and that's the problem with the prosthesis. It has to be correct from the first.
Very interesting hearing about all the different experiences. And actually, Zaf, who's on our committee but has been shy, has put a question up for us of what percentage of arthritis patients needing surgery do you do arthroplasty, do the prosthesis, versus which percentage do you do a trapeziectomy or something similar? So in your unit, Matthias, they're all getting arthroplasties now. You're doing a lot of trapeziectomy?
As I already said, recently, all our stage 3 osteoarthritis patients are receiving the touch prosthesis, and all stage 4 patients are receiving the RSA. And I would also like to add to the topic before, the ivory stem is compatible to the touch cup or the touch neck. I think Sumit was touching this issue before. And so you have a revision option because ivory is not available on the market anymore. You can revise the ivory system to the touch. I've read a case report on this recently. I think this may add to this question.
That's interesting. I mean, Sumit, you had some, you showed us some X-rays once. I don't know if you've got them to hand or not. Do you have them?
Yeah, I can share my screen if you want.
That might be useful, particularly for the plasticsy people like me who don't do a lot of this stuff. It gives a bit of context as well.
Yeah, I mean, so I think it should allow me to share.
Hopefully.
Can you see that?
Yeah.
So that is what we mean by center. So there should be no doubt in your mind that we are in the center of the trapezium. I think this is one of the things that Alan was talking about not making sure that you don't make a mistake. The other issue is to try and get it in two planes. So if you look at the MCP joint in this view, and if you look at the MCP joint in this view, it's comparable. So it's really important that you get views in two planes to make sure that the wire is dead center, because there's no substitute for positioning it properly. Get it right first, and then get your cup in. So if you do a true lateral, you see it's very, very difficult to tell where the trapezium is sitting. You can just about see the volar part. I'm not sure whether you can see my mouse, but you can see the volar part of the trapezium and the dorsal bit, and you've got you've got the cup sitting there, and a spherical cup was used this time, and this is with the prosthesis in, and this is what it looks like. So this was done in a cadaver. So unfortunately, because these prostheses get used a lot, effectively, sometimes they don't sit properly. And this is the point I was making to Alan, because if this patient now comes back to me and they say that, look, I've got a lot of pain, and you look at the height of the first metacarpal to the second, you just feel that, oh, have I perhaps over-lengthened it? You know, you have this movement there. So what Alan suggested was a very useful tip about using the position of the tip of the thumb and the PIP joint, and that's certainly something that I will look at going forward. That will be very useful. That's a very useful tip.
That's brilliant. Thanks, Ewan. Thanks for sharing that. We do have another question here, saying words. What about cash costs?
Yeah.
I don't know if that's referring to the cost of these implants. I don't know if anybody has any comments on that. Certainly not to me. I know anything about. Does anybody have any thoughts?
I think it's a very valid question. I feel that that's something which is one of the unanswered questions, because the trapezectomy does work. We know it works, and it works very well, and it has worked for so many years for us. There's no question, and Alan's proved it, that the joint replacement works as well. The question is that, does the cost justify doing something so expensive is the question. And you don't really have that. There isn't that body of work, at least from what I've seen, that can conclusively prove that. And to a certain extent, maybe a registry could, but that won't give the complete picture, because what you need is a properly powered clinical study that would compare the two. The issue obviously is that the trapeziectomy is so good that it'll have to be, to power this study itself will be difficult. So, sorry, Alan, go ahead.
I think the economy is not only in the cost of the prosthesis or the trapezectomy, but it's in the cost of the, if you return quickly to work, it's very important. Yeah. And with my team, we are preparing papers on this subject to show the shortening of the time to return to work. It's very important. You make an economy with the return quickly to the work. It's important to notice.
Yeah, I completely agree. I think a lot of importance to that. I mean, I think there's all sorts of really fascinating aspects, and you see progress in this field. We've talked through some of the progress tonight. There's still so many questions, things to explore. We've had an hour. It's flown by already, which is actually the end of our session, I'm afraid, today. I don't know if has anybody got any final comment on that, on what we think the future is? Do you think the double mobility, is this going to be the answer, Matthias?
Yes, I think it will definitely it will resolve the problem with the integration in the trapezium, which is now the major problem with most of prosthesis models. And if we manage to overcome this hurdle, we can compare RSA trapezectomy to the prosthesis and can add the better function of the prosthesis, and then also the cost of this product will be a minor argument in this, because return to work, faster recovery then will be the major argument for prosthesis. So yeah, definitely we will see how double mobility will work out in these topics.
Well, it's going to be really interesting to see. Thank you very much. We've got Lam has something to share with us about IFSSH. As we move on to that, whilst he's about to start that, I'd just like to thank everybody again. Thank our panel, thank our fellows for presenting, Obi and Carol. Thank our authors for joining, Alan and Matthias. Thank the experts. It's been really insightful having your opinions, Nadine and Sumed. Thank you, Tim, ever so much. And thank you to the team. There's a team behind the scenes who put this together, Matt and Christina and Sim and Julia, and the guys in the secretariat who make all of this possible. So thank you very much for everybody for that. And Zaf and thanks, guys. And you're going to play a short video for us now.
Yeah, can you guys see the screen? Yeah,
you're screen sharing.
Okay, right, I'm going to play a video for IFSH. Hope that will get everybody excited, okay? Okay, so that's the IFSH video. So just to say that abstract submissions are now open. The abstract submission deadline is the 15th of September. So not long to go now, but please submit your abstract and please visit the website ifesh2022.com. Okay, I hand over back to you, Jeremy. Thanks.
Thanks very much. And thank you again, everybody. And if you can't wait all the way till next summer for some more hand surgery chat, we've got another journal club coming up at the end of September. I think there's a short video about that. And other than that, I'd just like to say thanks again to our panel and the audience. And good evening, everybody, after our video.